Thank you, Patty, and thanks to all of you. We're so excited on this inaugural event, and I just want to offer my thanks also to CIHQ for the work that they've done to sponsor this. We are delighted. We're going to be talking about financial performance, the return on investment, looking at overall performance improvement, how we measure that, and the overall impact that we all can learn as we share thoughts and ideas. So I want to welcome you. I will say that I want to thank all the folks that have worked on this event. We have got such a tremendous response. And I would certainly be remiss if I didn't thank Angela for the hard work that she's put on this and really appreciate her being the special interest group chair for this event. And I'm also going to thank her because unfortunately I have to leave about midway. A good family friend passed away and I'm going to the memorial service. So I'm going to ask questions for the first part, but then Angela's going to take over and conclude the questions. We have an outstanding panel, and I'm going to let each of the panelists introduce themselves, but we have April Taylor with us, Rusty Lewis, and also Andrew Shea. April, why don't you introduce your first panelist, and then Rusty, and then Andrew, and then we'll go straight to questions. But April, welcome.
Thank you so much for having me. I'm joining you guys from Baltimore, Maryland, over on the East Coast. So hopefully the weather is a lot nicer and warmer for you guys out there in Texas. I am the Vice President for Quality Improvement at the Johns Hopkins Hospital. But I'm really fortunate to have worked over 20 years in quality, working my way up from a quality improvement coordinator to where I am today. So thank you so much for having me.
Hi, I'm Rusty Lewis, and currently I'm the Chief Information Officer and Chief Digital Officer for the Parkland Center for Clinical Innovation. I am not a PI, QI background person. I'm a technologist, so you shouldn't trust anything that I say, but my background really is ping-ponging back and forth between private equity or venture capital-backed small companies being acquired and going into big companies. So I've been the Chief Technical Officer for McKesson Corporation and Executive VP. I've been the President of the AmerisourceBergen Pharmacy Automation and Technology Division. Most recently in Dallas, I was the CIO and CTO of Vizient, and also their Group Vice President of everything related to data and analytics. And I spent my first 10 years of my career in a lovely Dallas company, Texas Instruments, running the parts of the computer science and artificial intelligence laboratory. And if you believe the old adage of failure is the best teacher, that makes me eminently qualified to be on this panel.
Last but not least, I am Drew Shea. I am the System Vice President for the Methodist Health System here in Dallas. I have been with Methodist about 3 years. I'm the choke-in hospital person in this conversation, as I've spent the majority of my time in the hospital world. I've worked both for-profit and not-for-profit. I spent the better part of 15 years with Tenet Healthcare. Also worked with Baylor for a little bit as part of a joint venture, and even a private equity-backed hospital company for a little over a year before joining Methodist. So have worked in many different areas and have worked with a lot of different of executive types and what they're targeting in this realm. Thank you.
Well, as you can see, we've got excellent panelists, and I'm going to launch into the questions. And I'm going to ask this first question to April and to Drew, and I'm going to ask April to answer first. But in your organization at Johns Hopkins, do you quantify every single performance improvement as you look at quality outcome projects if your organization? And if not, what is your selection criteria?
So no, we don't quantify all projects. I would say that the financial piece of it is often a nice to have, meaning that first and foremost, our focus is going to be on whatever our primary outcome metric is, right? So when you think about your QI project, you probably have structure, process, outcome metrics. Oftentimes, the financial piece is going to be a balancing metric where we want to understand whether our project is going to have a positive or negative financial impact. But if our main outcome is patient experience, right, or improving a clinical outcome, that's going to be our initial focus. The one exception is that if we have projects where there is an initial resource investment, so for example, the project is really focused in on some software or tool that we need to purchase, or we need to invest in some new FTEs, then ROI might be a stronger piece of that equation from the beginning, where we will need to have maybe a business plan as part of the process in project planning.
Great. Drew? I think you're on mute.
Can you hear me now?
Yes.
I'll echo what April said in that definitely if we are looking at adding a resource, that there's going to be, whether it is a physical resource, a significant contracted, we're going to want to be able to make sure that we have some metrics, both quality and from a financial standpoint, that we're able to measure. However, where we do a lot of work at improving quality, at improving patient satisfaction, there's a lot of fluidity to what those results are in those, rather than trying to put some financial target to something that may or may not actually have that result. We've made the decision that we don't want to get involved in trying to track every single thing we do for that reason. We want to make sure that when we're tracking something and when we're putting a process in place, that we have those tactics and those are hard dollars that we're able to show on a financial side. Not, we think we're going to reduce sepsis length of stay and that's going to mean $1,000 a day, when that last day of the patient's stay may cost $50. We don't want to overstate what we're doing. We want to make sure it's real value to the organization.
You know, those are some good points. And now I'm going to point to Rusty first and then to April. You know, quantifying ROI sometimes is extremely difficult. So what role does your PI and quality improvement team have as you quantify return on investment, ROI? And what would you say are some wins or lessons you've learned as you've been through this process?
So PCCI is a little bit of an unusual organization, that it's a combination of clinicians, statisticians, mathematicians, and data scientists. And the work we do is usually AI, predictive analytics, machine learning. And really the goal is to serve sort of vulnerable populations. And some of the strategies or the things that we have learned is got to get a great baseline, because there's usually a placebo effect in a lot of the things that we work on. Just the fact that someone is aware there's a quality or performance improvement initiative going, that changes the current state, and you get a beneficial improvement really when no interventions have taken place. So we typically try to measure a baseline 12 months pre-implementation and then 12 months sort of post-intervention. So that's one thing that we've learned. Another thing that we have learned is, there are some things that are very easy to measure and some things that are difficult. And a good example of that would be, we're involved in a pediatric asthma risk model, and we're trying to drive cross-organizational workflows and community-wide sort of care coordination. And so on that one, we have a great metric where we've seen a 42% drop in ED visits among sort of the patient cohort that we're following. But we also have things that are obviously really positive, but are difficult to quantify. Like we have an example where we're predicting the mortality in the next 48 hours for really severely injured trauma patients. And we can't quantify how many lives we've saved. We can't quantify how much better the outcomes are. But if we can predict the mortality risk and the features that would contribute to a mortality risk in the next 48 hours, then that helps trauma surgeons and orthopedic surgeons figure out, when should I stabilize a patient? When should I intervene? How should I sequence the intervention? So again, the lesson is, some things are hard. Some things that are obviously good are very easy to, are very difficult to quantify.
Good points. April, your thoughts on that?
Yeah, so I think, to piggyback a little bit off of what Rusty said, I think data is a big piece of this. And definitely, I think that's a role that the PI and QI team professionals have in this. But even just to sort of back up from there, I think about one of the things that really drew me into quality improvement and what I'm excited about. And that in quality improvement, we are problem solvers, right? Like, that's what we do. And so we really, our role in the team is that we come in as these external consultants, these external facilitators, and we ask questions, right? Questions that often that primary team that's coming to you with a problem, that clinical team isn't thinking about. And so I think one of the big roles that we play in sort of quantifying the ROI is that we come in with that questioning attitude and do the 5 whys, right? And sort of ask questions to really get at, what are going to be the potential impacts of this project? And by doing that, we hopefully help to sort of broaden people's focus a little bit. And that's how we really then get to, okay, there may be a financial impact here. From there, I think it's the right data, right? So you need to make sure that you're really thinking about, in terms of the lessons learned, that you're collecting the right data, that you're thinking about that at the beginning of the project and not at the end, because it is really, really hard to do retrospectively. One of the biggest pitfalls I see is that we're at the end of the project, and now a stakeholder that we probably should have asked at the beginning what they were really interested in, like the board, comes to us and they say, well, tell me more about the ROI, or tell me more about the financial impact. And then we're like, oh, wow, we never considered that. And now we're trying to piece it together retrospectively. Whereas from the beginning, we should be asking those questions. From the beginning, we should say, not just what the clinical team is interested in or what I'm interested in, what outcomes is the leadership team interested in? What outcomes might the board be interested in, particularly around the financial piece? And how do we build that into our measurement plan from the beginning?
Boy, I tell you, you're bringing up some excellent points. And so I'm going to turn to Drew and Rusty for my next question, but I'm going to piggyback a little bit off of what April said. And for full disclosure here, my career is similar to Drew's. I worked in investor owned. I'm a recovering CFO, so I try to think in terms of return on investment and how you quantify it. But April brought up some excellent points. You've got to involve the board. You've got to involve the executive team. And so you have to think, how are you not only going to share the value of what you're doing with the project team, but also the executive team and the board? So with that said, Drew, what are some key strategies on how you define at the outset what the return on investment is going to be? And what strategies do you employ?
So I've been blessed to sit on both sides of those conversations. One being the person developing these strategies and selling it to the executive leadership, and also being on the other side of that conversation and really sitting at the table, hearing people present it to me. The first thing that, in terms of what key strategies, what lessons I've learned over the time, it's important to know who your audience is right off the bat. If you're presenting to a very clinical focused individual, even when we're talking about board members, hospital CEOs, presidents, we see folks come from all different walks of life into those roles. And it's really knowing what they are focused on and what they're looking for. You may talk to a executive and they've been a CFO for the vast majority of their career, and we're all focused on, what are those nitty gritty numbers? whereas you have another individual in a similar role, and they came up through quality improvement, and they don't understand and aren't as comfortable with the numbers, but they want to know what the true patient outcome metrics are that you're defining. So I think before you even look at the data that you're going to collect, you really need to know the audience that you're going to be presenting this to initially and at the end of the project, and really shape it towards them. For me, coming from the investor side of the world, we definitely wanted to understand the ROI on the project. I needed, even if it was being presented to me, I needed to be able to sell it to my regional division corporate leadership that, yes, this is the right thing to do for the patient, and we're going to keep the patient safer, get them healthier. We may see our volumes decline by aligning with the local community clinic, but it's the right thing for them. And here's how it's benefiting us. And really drilling it down towards them. The biggest pitfalls that I have run into, and I've stepped on a few landmines in my career. And the biggest ones were always where I misjudged who I was talking to and who I was presenting it to and what their focus was going to be. So I would say the key thing is to know who that is. Because through Methodist, if I'm presenting this to Craig Berkey, my system CFO, or to Pam Stoynoff, our system president, my tactics and how I go into that meeting are very different, because the two individuals have very different personalities. And at the end of the day, knowing that if we're looking at a culture of safety rollout, that, and just culture, we know that's going to go to the board. So knowing that ahead of time, I need to, one, prepare for selling it to Pam and Dr. Koonsman, our CMO, of the importance of it, but also knowing that this is going to community board members who have a different focus. So we're going to have that in our pocket to begin with. And I rambled for a long time on that, but I'm something that's hard.
Not a problem. I think you both gave great answers. I'm going to put April a little on the spot, and Drew, I'm going to put you back on the spot a little bit. It's kind of an unfair question, but in your own organizations, what is the level of interest related to performance improvement projects looking at return on investment? And what is your role in performance improvement within your organization? We'll start with you, April.
So I think, in terms of the level of interest, it's moderate, I would say, meaning that honestly, to whatever extent possible, we want to be able to quantify our work. And we want to be able to quantify our work both in terms of that primary outcome, so clinical outcome, provider experience, patient experience, but also, if we can, certainly that financial outcome. It really depends, I think, on the project and the work. Currently I do work, in the sort of acute care space, although we certainly have ambulatory practices. Before I worked in my current role, I did a lot on sort of the physician practice side. And for a lot of hospitals, right, you have these pay-for-performance programs, right? And so when you think about a lot of these pay-for-performance programs where there is a reward or a penalty, that financial piece becomes really important, and looking at not just the sort of local cost of projects, but if we need to prioritize our improvement projects, because you can't do 50 projects, right? Maybe we need to focus on like our top 5 for the year. We might look at, well, what's the impact going to be in that pay for performance program? What is the project where we have the largest penalty, right? And maybe that's going to then help us in terms of determining our strategic priorities for the year. So I think that there's lots of different ways you can sort of quantify projects, right? Cost savings versus cost avoidance. Are we talking penalty? Are we talking reward? Is this a project where there's an opportunity to generate revenue? So I think depending on the project, that's where that level of interest and how much we spend on it sort of comes into play. I will say that for me specifically, in terms of what is my level of involvement in the PI and QI work? As I mentioned, I've grown up in quality improvement. This really is my career. And so although in my current role, I'm the vice president for quality, and I do a lot in setting our strategic direction and working with our leadership team because I report directly up to the president of the hospital. I like to get my fingers wet, right? I like to get my hands dirty. So I still am boots on the ground working on improvement projects. I try to do a couple per year, and that actually helps, I think, to ground me with what the actual problems are that we're trying to address, and then working with my team to help make sure that we can think big picture around quantifying our outcomes, whether they are financial outcomes or not.
Great. Your thoughts, Drew?
I would say that overall process improvement at Methodist is a very high focus. The quantifying of it, I would say, is moderate to high as well. We are in a position where we want to make sure what we're doing is having an impact, and what impact that is. Overall, the knowledge that any of these projects that we put in place, it's gonna have a give and take on our ability to do other things. So there is a strong look at the executive level on, does this make sense right now? I mean, overall, we're making high investments in these areas. For those who are knowledgeable about Methodist Health System's makeup, we have 2 hospitals that sit in the southern sector of Dallas, which they are our 2 largest hospitals, but they're also in very challenging communities. So we have a commitment and a mission to serve these communities because historically they've been underserved, even within a very competitive environment. So we want to make sure what we're doing in terms of improvement isn't going to cost our ability to meet that mission that we're so committed to. Personally, I'm very involved in the quantification of it. I work with our QI team, and we have a project deployment office that, when working on it, I am responsible for really the final confirmation of the dollars that go to the executives. So I'm meeting with the leaders of any project, whether it is quality or cost avoidance related, and making sure that before we share anything across the system, those numbers are real. Both on what we're saying the impact has been on the soft side plus the hard financial side.
Great. I'm going to go to another question, but before I do, I want to remind people, if you have questions, please put them in the chat box. I know Patty is monitoring that. And this will be my final question, and afterwards, Angela is going to take over. But we're going to ask this to all 3, and we'll start with Rusty, and then we'll go to April, and then we'll go to Drew. It's interesting. Most systems, hospitals, have some kind of scorecard or some kind of dashboard. Do you include performance improvement on that dashboard or on that report card? Do you even include the return on investment or some of the outcome impact that you see? And if your answer is yes, can you explain to our audience how you gather the data so that you can, in fact, put that on the report card? And with that, I am going to sign off, but it's been an honor and a privilege to be here, and Angela will take over from now. But Rusty, you'll do the first answer to that question. Thank you.
Sure. So let me just take a second to add some contextual information. So I just want to echo April and Drew's comments that it's usually not a single stakeholder that makes a decision, and you have to speak in the language of the stakeholder and in the level of detail that's sufficient for them to understand the ROI to make those prioritization decisions, because at least in the Parkland Health System and the associated Parkland Health Plan, it's a zero-sum game. we've got sort of a pot of funding, and we have an infinite amount of demands, and we just got to figure out which things that we kind of bite off. I would say that we do an annual impact assessment where we do have a scorecard that shows, and I wouldn't say in great detail only the financial impact. It includes things that are indirectly financial, like increasing capacity, easing access constraints, improving quality, improving patient safety, recruiting and retaining staff, but there are also financial metrics in that. And that impact statement that we generate really helps determine what we're going to do in the next fiscal year. So that's a pretty important thing for us. But also something that we started to do a few years back that I think is related to this and interesting is we've learned to be careful what we ask for. And we've learned a lot about the law of unintended consequences, or every action has a reaction. And to give you just a couple quick examples of that, back when high margin bundled payments for hips and knees came in, boy, we were really working that hard and getting people shortening the length of stay, and that resulted in sort of 30-day readmissions increasing, so unintended consequence. And we even have one now. So we have a project that we've worked hard on this year that's very successful, and it's on predicting the probability of patients who didn't have sepsis on admission, but developing sepsis while they're in the hospital. And so we're making those predictions. And so we have a pretty high positive predictive accuracy. For every 100 patients that we predict will have sepsis, 34 of them would have actually developed sepsis, and we're able to administer antibiotics much earlier in the game and sort of reduce the severity of that impact. Unintended consequences, I can get 34 out of 100. What happens to the other 66? Those are alerts that go to physicians, and so they get fatigue from dealing with those alerts. So we're looking at the positive ROI, but we're also starting to report out now on what are some of the unintended, maybe potentially negative consequences of the work that we're doing as well.
Yeah, so I think, to chime in at a high level, yes, we have an organizational sort of KPI dashboard. And within that dashboard, we then have quality KPIs that are tracked and, cascaded throughout the organization all the way up through the board level. I would say that generally speaking, ROI isn't going to be captured there simply because we don't necessarily have ROI on every single project. Usually ROI is going to be captured on project level documents like an A3, for example. With that being said, for something like a pay for performance program, value-based purchasing, on our overall dashboard scorecard, we do have information for where we fall within sort of that penalty reward zone or sort of our projections. So I think it sort of depends on what your KPIs are and sort of what are the metrics you're looking at. One thing I should comment on as we think really about ROI, so the financial piece and sort of quantification of this is, what does that look like in terms of operationalizing that? Because I know one of the questions was around sort of the operational definition and the data collection plan for those sorts of metrics. And what I will say is that I'm a quality improvement professional, right? And so I really feel like my subject matter expertise is in quality improvement and also in analytics. I really rely on my subject matter experts in professional billing, so like physician billing, APP billing, hospital billing, or if you work in the insurance world, the folks that are on your claims team, right? Those are really the folks that are the experts in the financial piece. So I really want to highlight that I engage with those stakeholders in helping us think through exactly how we're going to collect that data, what data is available, and how we're going to quantify and display it.
Great point. Drew, we cannot hear you.
Yeah, it's because I keep muting myself and not unmuting. So I apologize about that. I would agree with both Rusty and April. We do have a system-wide dashboard that we look at a lot of our PI and QI projects. We do have some They're not a lot. It's usually the larger, a lot, I don't know how to say it, that are cut and dry that we're able to track. That we have some ROI for those on there that we track in trends. The reason being is that if, I guess our system view, and quite frankly, it's no different than the other systems I've worked with in the past, is if we're not looking at, on an ongoing basis at that ROI, developing it at the beginning was pointless. Because if we don't know where we stand, why did we do it? And then at the end of the day, when the project's over and has turned into, gone from being an outlier versus how we're supposed to be operating daily, how do we know what that impact's going to be? So we do keep track of those where it's possible. Like Rusty brought up, we do try to look at the good and bad. Yes, every action has a equal and opposite and sometimes worse reaction. A hospital that not my current system, but a hospital I was with previously was looking at reducing the length of stay of our bariatric surgery patients. Well, it was great that we were getting them out of bed earlier, we were getting them moving around earlier, which would help with their recovery. But what we were seeing was an increase on the back end, of them having a much higher reoccurrence of being readmitted 7, 15, or 30 days out. So yeah, we reduced down a little bit of cost and we saved $100 here or there, but the $50,000 in that readmission cost us a lot more. So we try, not everything's easy to find those unintended consequences because sometimes they slip through the cracks. Overall, the key is do you have a question?
No, I was just signaling Angela. I had a comment to make.
Oh,
After
okay. So it's not always easy to have to really build out that, but I think the key through it is no operational definition you come up with is going to be perfect. No data collection plan you come with is going to be perfect. I think the key is going through and making sure that you can justify and quantify any issues that you find through it and keep everything consistent through the process and not change. If you make a change because you find something that you missed 6 months in, don't just start with 6 months in's data, because I've seen that happen, and you just start seeing the operational definition change over time. So with that, I will turn it over because Rusty has a comment to make.
And so this is a short comment. So I spent probably 32 plus years on the dark side of being a vendor of product services and consulting services. And I probably have engaged with hundreds of health systems. I have never seen a CFO or COO ever give a vendor return on investment credit when they say that there's going to be a labor reduction. No one has ever been fired in the history of anything I've ever done. They may have been repurposed for other things. I just wanted to share that to the vendor community who may be listening.
I appreciate that. One of the things that, from my perspective, and I think the teams that I talk with are boots on the ground. They're the people that are very much, part of April's team and, the kind of folks that Drew and I engage with. And when we talk to our folks that are boots on the ground, the questions that they usually ask me is, well, I'm new to this, or I'm trying to make sure my senior executives are understanding how I'm going to walk through this quantification journey. What are some questions that that performance improvement or quality improvement project team could ask their financial counterparts or those key stakeholders that April identified from billing and so on to get started on an ROI journey? And I'm going to ask April and Drew to address this question. And Drew, since you actually were talking a little bit about this already, I'm going to ask you to start first, and then we can hand it over to April.
Ouch, Angela. Since we work for the same company, you're supposed to take it easy on me. So I just want to make sure I answer this the way I'm thinking. So I think the key is to have those conversations early and upfront, so that both sides, because as a quality focused individual, whether it's quality improvement, clinical in nature, process improvement, you have a certain set of gifts. You have a certain set of knowledge, and you got skills you're bringing to the table. And you have a way of picturing things in your head. On the other side, you have, whether it's in billing, whether it's in finance, accounting, whether it's in supply chain, those folks have a different way of looking at it. And what I found over time is we can have that conversation multiple times, and the two sides are talking two separate things. And I've been the problem in a couple of them that I'm mishearing. So when I've been asked, we've worked on projects, and it's some of the more difficult and timely ones, like using UTI reductions. Every hospital on the face of the planet is working on a continuous project to reduce down urinary tract infections. And when I worked on this within Tenet a decade ago, and we started rolling out a process change, I was meeting with the clinical lead on it, and she was asking me to pull specific data sets, and she was giving me specific codes that she had already gotten from our health information management folks. It took 4 or 5 times of me pulling that data to get what she wanted. And it wasn't that it was asked wrong. It was I heard it differently, because I interpret things different. So I think the key really is to sit down, as hard as it is in this COVID world, face to face, even if it's over Microsoft Teams or Zoom, is much better than via email or text, to be able to get across what you're looking for, allow back and forth of questions to be answered, because sometimes that solves 5 meetings turning into 1 or 2. I can think of an example here on a project we were working on in reducing the cost of surgical mesh, whether it was from a clinical need standpoint, the type of mesh, the size of mesh, everything mesh related. And between our medical leader of the project, our quality leader of the project, and our financial leader of the project, who I will not take credit for being me, I was the final quantifier, it took literally 4 or 5 meetings before there was able to come up with an operational definition of what a patient who had mesh in their surgery consisted of. So it's things one side thinks is easy, the other side may not hear it the same. So once again, I rambled again. I apologize. Gave April plenty of time to think of her much more eloquent response.
So I think, at the heart of this, are there magic questions to ask? I would say that at the highest level, the basic question to ask of, the group, assuming you have the right stakeholders there, so you want to make sure you have the right stakeholder group assembled, is there financial impact related to this project that we should be thinking about, right? And I think, as Drew said, asking that question at the very beginning. And so, knowing you guys are PI, QI folks, right? If you're doing a lean project and lean is around decreasing waste, I'm thinking that there's probably going to be some sort of financial impact within that, right? You need to just ask that broadly of the group. So now you guys can drill down and really think through, okay, well, what would be the potential sort of financial impacts, right? Depending on if, we're going to become more efficient, so maybe we're going to use less resources or, whatever it may be. And if yes, how is it that we can then measure it? So is there a financial impact? How will we measure that financial impact? Who do we need to engage in making sure that we understand the financial impact at the end of the day? So for example, I'm working on a project now. I was there at 7 a.m. Again, I like to be boots on the ground. So I'm working on a project with our central sterile processing team. And so this project is related to reducing missing instruments. And how this project started is that we had a lot of complaints from surgeons and other folks that said, we're in the OR and we open up our case card and there's instruments that aren't there that we need that are critical to that surgery. And this was really around provider experience, right? Because they were unhappy about it. But also then, that creates late starts in the OR. Again, maybe a patient now needs to be under anesthesia longer, right? So that's really how we are approaching the project. But I'm sure you guys can think that there probably is a financial piece to this that we can also quantify, right? So when you think about missing instruments, as we start to drill down, identify the root causes of the problem, et cetera, we did FMEAs, all kind of stuff, is that, oftentimes what happens is that people accidentally throw away non-disposable instruments and then therefore they go missing. Or maybe in between the process of it coming, down to go being decontamination and then central sterile, it gets filed in the wrong case card or something like that. Well, what happens is that as instruments go missing, but we need them because they're critical for a case, we buy more and more instruments. And now we have more than what we need because we bought all these extras because we threw stuff away or we actually have stuff. It's just not in the right spot. Right. So there is a financial burden to that if we clean up our processes, we can actually quantify maybe how much we're saving in terms of supply chain, but not needing to buy a whole bunch of stuff that maybe just was in the wrong sort of case card, as an example. Switching back to sort of that ROI side, if you're thinking about that initial upfront investment, so you have something where you're asking for software, you're asking for a tool, you're asking for resources. Again, that's a little bit different where from the beginning, you will need to ask questions around, okay, if we make this investment, what will the return be, right? And just having that question out there and starting that dialogue with stakeholders will help you to at least get enough information to work with the subject matter experts in finance to figure out how will we track that. And sometimes you need to be creative. So I don't want to underestimate the fact that you're going to have to do some independent research, right? You're still going to be out there on your own looking at or networking, benchmarking with other folks to say, how are other folks quantifying this? I'll give you one other quick example is that I worked on a project previously looking at customer lifetime value. Now, customer lifetime value, often that's not thought about in healthcare, right? Customer lifetime value is this idea that often you have folks like, Comcast, that through all of their little statistical models, they can sort of estimate that if April gets Comcast, in her 20s and she stays with us for 20 years, in addition to like the monthly stuff, if I, get DVR and some other movies, like here's how much lifetime value I have to them as a customer. Well, we did something sort of like that, but thinking about it related to patients accessing specialty care. And here's why we did it. We had a lot of issues related to access to care for specialty care, right? So sometimes you look at something like days to third next new appointment. And we said our days to third next new appointment isn't great. We think that we're losing patients, right, to other health systems because they can't get in for specialty care. Not only does that impact the outpatient specialist, but if it's a surgical specialty, impact surgeries, right, coming to the hospital. So we said, okay, great. What we want to do is we actually want to put some resources here, right? We want to add in some new schedulers. We want to add in new access coordinators. Maybe we want to add in some new APPs or PAs and change up our care model to reduce the wait time for new patient appointments. Okay, but that costs money, right? So now we need to think about how might we quantify what that looks like in terms of return on investment. And as it turns out, like the easy answer is like, okay, well, for each patient we get in, we know that there's like a cost and charge to that, right? But it's actually bigger than that. So that's where this idea of customer lifetime value came in, where we said, well, it's not just the single appointment. For any one patient that comes to us for asthma, right? If we anticipate that they're going to be with us for X number of years, there's a a lifetime value to that, right? So we actually found a way to better quantify what this might look like to really justify bringing in the additional resources and tools we needed to ultimately reduce that time to next available appointment.
That sounds like an amazing project and conversation. I'm sure that folks are going to clamor and reach out to Patty and I after this, April. Are you able to share some information on that? Maybe if there's a publication or something that you've done around that CLV project, I'd love to make sure our audience has access to it.
Yeah, absolutely.
Perfect. I know we're coming up on that 10-minute mark, and I see that our folks in the audience have a couple of questions. So before I jump to that, I have one last kind of pre-selected question that I want to make sure we ask of all our panelists, and then I'll turn it over to audience questions. From my perspective, and as I've been talking to each one of you offline and Steve and chatting about this topic, I realize that you know, the world around us is evolving, especially in terms of data analytics, quantification, and that entire journey. Can you tell me a little bit about how, from your perspective, artificial intelligence could be leveraged to quantify these outcomes for our performance improvement projects, either on the quality, you know, improvement perspective as well as the financial improvement perspective? And I'm going to start with Rusty. So we give April and Drew a chance to get their breather, and then we'll go to Drew and end with April.
Well, this is somewhat the sweet spot for me because that's what I do day in and day out for the last 5 years is AI stuff. So I would say, first of all, AI is not rocket science anymore. Building predictive models, machine learning models, things of that nature, that's become essentially mundane work that anybody with a good statistical math background, even people with computer science degrees that haven't been trained as data scientists, can actually do some pretty serious work because the tools exist. The challenge with that is, as always, is access to data. So when you build an AI system, you know, you've selected sort of features of importance, and based on those features, you can really track just about any outcome you want. I would say, though, here's some areas to be concerned about. When you're using AI and you're training an AI system, you typically do it using historical data. Part of that data is used to train a system. Part of it's used to validate the accuracy of that system. Based on your historical data, you can build bias into those systems. So it could be racial bias, ethnicity bias, gender bias, age bias. So really want to be careful on that bias. I would also say that you can make models that are more accurate than any person can be, but the explainability of those models is a real challenge. Oftentimes you can't determine why a model made a decision, gave you a probability score or a risk score, or advised you to take a particular action because the explainability is a kind of a challenge. I would also say that when you build models and a model will give you a prediction and tell you, here's the features that cause that prediction, and that model is intended to do some sort of risk mitigation or performance improvement, there are certain kinds of risks that you just can't medicate. For example, you could measure what is the medication adherence rate for people taking specialty medications. And if the barrier for them is a financial barrier, you can't offer them incentives if they're a government pay Medicare, Medicaid, because if you lower the cost for one patient, you lowered it for every patient for sort of the remainder of that year. So I think AI is increasingly going to become sort of a mundane standard part of everybody's tool set. And certainly for us at PCCI, we measure everything from financial impact to outcome impact to operational efficiencies, and models allow you to do that, but only if you have the sources of data, and the data is really the key to everything. So that's my 2 cents.
Appreciate that, Rusty. Drew, what are your thoughts?
Yeah, once again, you had me go after Rusty on this one. You did not set me up to win. We're going to talk.
It's not a
I
competition.
mean, Rusty's experience true experience in terms of AI and its usefulness across the system is much greater than mine, by all means. But I see it as a major advancement that has been utilized under different names for the past number of years. And just with the sheer volume of data that is in the size of that data becoming available more and more, it is going to go from more of a cutting, bleeding edge technological view to realistically, it's going to be the norm. At the end of the day, from a billing side and a collectability side, because I can go back to the financial side of the world for me, from a data scientist and statistician view, we as hospitals, at least the systems I've worked with, have been carving up patients and slicing and dicing them for decades. As technology advances, how much we can carve it down has expanded exponentially, but we were able to predict based on a person's geographic location, income earning level, and some other focuses that we could say if we were going to get $100 out of them or $500. So now it's great that the technology is really staying up with and advancing as quick so that we can be looking at this in terms of the quality side of this, being able to predict mortalities and reduce errors by catching things before they happen. To me, it is going to be a major thing. It's the one piece that AI will never have the ability to until we're in the land of the Terminators, is to really foresee things that you can't see happening. I mean, there's no way I hope AI didn't predict COVID happening. If you knew about this, Rusty, and didn't share it with me, I'm kind of sad. But I mean, these once-in-a-lifetime things that we don't know are going to happen until it hits. So we're still going to need the human element to pivot on those as well. So now, April, you're up.
Andrew, can I make one comment?
Yeah.
And it's a quick comment. So I would say that there is an exponential advancement in the rate of sort of maturity of AI. Exponential advancement in the rate of the Internet of Things and wearables and sort of health monitoring and sort of the convergence of those things. I bet every health system here has a team that's focused on their digital strategy and how to reach out to patients sort of virtually as opposed to sort of face-to-face interactions. And I think sort of AI is going to be a great enabler for those types of encounters in the future.
Absolutely.
April, you're up next.
So I'll be super brief so we can get to some audience questions. I think I'll just take it back at a high level. And I think the important point here is like how important data is when we think about quality improvement and performance improvement. And oftentimes folks that aren't in our fields, right, they say, oh, well, data, we're going to use that at the end to measure whether or not we've improved. And that's not the case, right? Data is used throughout all different phases of improvement. We need data to figure out how we're going to prioritize what projects we're going to work on. We need data to then figure out the interventions we're going to target. And then you're also using data to measure improvement. And so when I think about like the AI piece of this, AI has currently and also has that potential to really help us figure out what patient populations should we target. It has the ability to help us really sort of tailor our interventions a little bit. But I think going back to Rusty's point, it's only as good as what we can put into it. It's only as good as how well you sort of train the model and sort of keep it up to date. And so I do think that some of the current challenges is that you have some models and things out there that maybe aren't working as well as we'd like, or they're sort of out there and people don't actually ever sort of update them and they become a little bit stale. I think those are some of the challenges that we have to face in the future.
Thank you. I love that rapid fire response to that, April. I know we have 2 minutes on the clock, so I'm going to end with this last question, and if you can keep your responses brief, and then we'll actually transition to the discussion portion or the networking portion with the team. For our panelists, everyone is welcome to stay for the conversation, and we may continue to chat a little bit more with audience questions at that time if you're available to. And if you need to hop off, then in advance of the ending, thank you for your time and your amazing expertise on this. The last question is a combination of two different questions in the chat. It truly talks about how do you leverage relationships and procure data between quality and finance and supply chain to help with this conversation that we're having? And the tie-in to that is, how does data literacy and alignment across these different teams really help address that information gathering process? And I'm going to start with Rusty's like, I don't want to talk about that one. Okay, so let me start with April, because we ended with you earlier. I'm actually going to have you answer that one, and then we'll go to Drew on that next.
Yes, I think the big piece right from the beginning is that you need to build collaborative partnerships, right, with all the folks that you need to work with to get quality improvement done. So that includes your clinical analytics folks, financial analytics folks. You need to have them engage from the beginning as stakeholders. To me, the biggest pitfall I see is that there's like some data mart out there, right? Some self-service data, and you take financial data and on your own, you try to analyze it, and then you show it somewhere, and the finance people see it and they're like, nope, you got it all wrong, right?
Yep.
Doing that will put a bad taste in their mouth, and they're less likely to want to work and partner with you, because they're like, well, why didn't you come to us, right? Why didn't you engage us from the beginning and helping you to think through the right way to sort of quantify, or making sure you have the right data? So I think it gets back to that stakeholder conversation, and right from the beginning, how do you get the right stakeholders involved and say, hey, sort of pat them on the back. We need your help in figuring out how to quantify this, right? We need your help in this data that's going to be super important for this major sort of strategic objective. That really shows that you are respecting their expertise. And by doing that, you can come together as subject matter experts and figure out what is sort of the best metric, what's the best way to display it, et cetera. But I think it's that early engagement, partnership, and collaboration.
Absolutely. Drew, I feel like you're the other half of that conversation or that equation typically. So what is your thought on that?
I agree 100%. It's getting the right people there right at the beginning. It's marrying folks up together because as much as we like to look at a EMR or a financial report and say that this is quote unquote the source of truth, there is no one source of truth in this world. You're going to have to work with multiple data sets and multiple areas in order to do this, and you need to get the experts around the table. And the great thing to me is the average person in healthcare, whether they're a doctor, a nurse, or an accountant, we actually like to see something come about from our job. So even the scary, boring finance folks, they want to see something do good. They want help. They want to help and see that what they're doing makes a difference. So my feeling is get them involved from a financial side, get the financial people involved. They do know how to help with this. You're going to have to reteach them the language, but they're going to be there to support it, to help it. And when it gets up to the senior executive world, it's going to end up back in their laps. And as it was said, the worst thing to happen to any quantification is for finance to say, yeah, this is all wrong. Because rebuilding that trust in what you provide at the executive level, it's going to take 10 times longer to get past, because there's going to be a taste in the executive or board level of, well, okay, so I hear this is this, but let me have somebody else confirm it for me.
I appreciate that insight. And I can tell the folks on the call, from my perspective, in working with performance improvement projects at the doer level, let me call it that, it's been really important to partner with my friends on the financial side of the house. So, Drew and one of his team members and I've built that collaborative relationship where he is included as a partner on my improvement projects, especially the strategic ones that we're working on, so that we can start hosting those conversations early on. I think just as important as building that relationship is having the executive support. So working with my leaders and his leaders, which would be Drew, making sure we're all aligned and on the same page helps getting that information and prioritizing those requests so that you get the information in a collaborative and timely manner. So with that, I'd like to say thank you to April, Drew, and for Rusty for being on this panel and for spending time with us, for giving up your lunch hour to chat with us. And we really have enjoyed learning about your different organizations, your leadership styles, and your perspectives on how we can approach this. Patty, can I turn it over to you to transition us from this section to the next?
Yes, you sure can. And I too want to thank the panelists. Great information. I'm really looking forward to the discussion we're going to be having in our meeting. As Angela stated, anybody who needs to leave at this time can, but we're going to continue some discussion about what we learned, priorities, and continue from there. So we're going to keep, because there is still almost 100 people on the call, we're going to keep videos and cameras off. So panelists, if you're sick of, having a smile, you can turn your cameras off if you want. We're going to ask some questions and we'll have you put it in the chat. And if you feel like you want to elaborate or Angela mentions your comment, raise your hand and I can open your mic so you can talk to us or just continue in the chat with us, okay? I'm going to share my screen and we're going to move on to the meeting portion of this. So we want to give you a little bit of background.